The last speaker of the session is Anne Lord Bailey. She's there. Executive Director of Strat Lab and Immersive Technology for the VA's office and Health Innovation Learning. Well, I don't think I have to introduce her. She's well known, prestigious awards.
Infamous.
And particularly in immersive technology.
Well, thank you. Thank you so much. For those of you who are wondering, we are still in MXR around the world. So if you think you're in a different session, I think we're running a little bit behind. Thank you so much for allowing VA to be here and have a voice. So many of you in the room are a part of this story. I get the honor to present today, but I just want to make that known. There are a lot of people in this room that are not VA employees, but none of this would have happened without you all. So thank you so much for that. First of all, who's familiar with what the VA is, Department of Veterans Affairs? Awesome. So we get a lot more response from that than we used to, for sure. I'm pushing the big green button, is that correct? Okay, awesome. So what we are is the largest integrated healthcare system in the United States, serving more than 9 million enrolled veterans. That's not all veterans, that's just the veterans that are enrolled. We have nearly 1,200 sites of care, 172 medical centers in all 50 states and also in some of the American territories. We have 400,000 healthcare professionals, 25,000 volunteers. So to say the least, a very complex organization. We also have a deep history of innovation. A lot of people don't think of the government necessarily when they think of innovation, right? But there are several examples that you can see on this slide that highlight and emphasize the fact that there are things that are now normal in healthcare, things we don't even think about, right? Liver transplants, cardiac pacemakers, nicotine patches, telehealth, BCMA barcoding. Many of those things began in the VA, and we are absolutely thinking about immersive technology being another opportunity for VA to prove, along with so many of you in this room, that this really is transforming healthcare delivery and experience. So one of the things we always like to make clear, we are a large government organization. I like to keep the ethics attorneys happy, as well as some of the other programs in our office, right? We don't endorse any particular product or company. Hard stop. We also are using this technology in support of clinical care. It's a tool. We're not yet replacing clinicians. We will never replace clinicians. We will be augmenting clinicians forever and absolutely augmenting clinical care. But just want to make that clear. Another sort of fun fact that we like to highlight is we're not using any stock photos. These are all our actual patients and our providers using this technology in care. I think.
Okay, hi, I'm Carrie Ann Shulman. I served in the Women's Army Corps. I'm very proud of that. And I was having problems. I was sleeping a lot. I had no energy to do anything. So I had no idea that I would actually physically benefit from it. Because most people see it as games. No, it wasn't. In the headset, besides the meditation, I started seeing some exercise things. And I was like, let me try it out. And that's what started it.
And my favorite one is she has improved grip strength. So every assessment I measure veterans' grip strengths with a tool called a dynamometer. So incredibly, with a progressive disease like MS, you would expect grip strength to decrease over time. Actually, Carrie's is improving. So within the last 2 years, it's improved 8 to 10 kilograms of pressure. So that's just incredible to see that.
I want every vet to be able to do that, especially the older ones and the ones that are out in places like me where you're kind of alone. It's a lifesaver. Being immersive is going to save lives. It really will, literally save lives.
This is one of my favorite stories, Carrie. What's interesting about her is as much as we are doing with implementation and deployment across VA, We actually found out about Carrie through a community I'll talk to you a little bit about, but a supervisor of a dietitian of one of our home-based primary care teams sent me an email, and he said, I think you need to hear this story. So a dietitian went out for an annual visit to see a patient with a progressive disease and saw improvement in grip strength, improvement in mental health, and emotional well-being. And she couldn't figure it out because this is a progressive disease. They expected a certain amount of stability at best, but decline is more anticipated. And she started asking Carrie, what changed about your life? What are you doing differently? Because this is something we need to harness and make available to more people. And her grandson had allowed her to start trying fishing in VR, right? It wasn't an intentional healthcare intervention, but what we're finding is even in those places, there's certainly clinical impact. And we want to harness those things. We know what you'll see. I've been sitting through many of these sessions and very grateful for them. Lots of p-values and datas and n's and things like that. And that's all critical. And we're building all the same kind of rigorous evidence. But I also don't want us to miss those individual patient stories and stories of impact where we're reaching people we didn't know we could reach. And Carrie is certainly one of those stories. So a little bit about the history. Many of you know this. For those of you who don't, in 2017, Caitlin Rollins, who is the VA Immersive Program Manager now, was a bedside nurse in Asheville, North Carolina, and had an orthopedic surgeon come to her and say, hey, have you ever thought about virtual reality? She was looking at opportunities to help decrease opioid use, decrease length of stay, particularly following knee replacement. And so Caitlin's history is she was a graphic artist prior to becoming a nurse. So you can see the natural intersection, right? So she starts exploring this opportunity, reaches out to VAs. Remember, 172 medical centers, almost 1,200 sites of care, 400,000 staff, 9 million veterans. And no one was able to say that anybody was doing VR at the time. They certainly saw the opportunity and the potential, but no one was doing it. And so Caitlin got to work trying to figure this out, nuts and bolts, bring them together. I was an innovation specialist at the time. It's fine if you don't know what that is. Basically trying to build the culture of innovation in the facility. I was also practicing a pharmacy practitioner, seeing patients. And so she brought this to me when she had a little bit of data. And from a pharmacy perspective, anytime you can get people to use fewer opioids, you're increasing engagement, the clinicians are willing to use it, you're decreasing length of stay. It's a very natural step to say, we need to do more of this. And so we started to figure out, at the time, now that we know what we know about VA, we thought nobody else was doing it. But actually, there were 6 or 7 VA medical centers that were already using VR in a few different areas, some staff education, PTSD, anxiety, things like that. But nobody knew that anybody else was doing it, right? So that means the same lessons and challenges and burdens and barriers. Marie said, she was talking about many of those. People were having to figure that out over and over and over again, which was killing momentum. So we saw the opportunity, learning from another group in VA, the 3D Printing Network, to bring some collaboration and build community around this concept. So what we did was created what we now call the XR Network, or the Extended Reality Network. I'll tell you a little more about what all that means. But because of that network, now we have documented more than 40 different clinical indications for use. We've got headsets in all 50 states, as well as other American territories, American Samoa, Puerto Rico, and Guam. And these are just a few examples of some of those indications for use. Some of them are training and education for sure, but many are based on clinical indications. And this is not exhaustive. This is just a quick snapshot of some of the places. I love this one too, because to your point about the NHS, we're in deep conversations with them to see how we can learn from each other across the pond. Like, that's how this technology helps bring people together to change healthcare. This is actually was when the Ukraine delegation came to the San Antonio VA, right? So we've got people from all different countries experiencing this as well. Some of the things we've seen with that engagement. Now we know of our 172 medical centers, 154 and 18 additional sites of care. So our vet centers, which are more community-based, less clinical, more convening types of places. Some of our community-based outpatient clinics now are also using this technology. Our team alone, the VA Immersive team, is overseeing 24 different implementation pilots across 165 unique sites of care. So we're hustling. 44 states and Puerto Rico. Puerto Rico snuck in there with us. We like having them as a part of the team. And we've documented at least 3,000 unique veteran uses and 7,000 experiences. That's with our data being sort of built as we go. So we know we're missing a lot of data, but still that's not an insignificant amount. Also want to emphasize, I started with this, but want to say it again, 57% of what we do is collaborative. Everything we do is collaborative. 57% of what we do is collaborating with industry. So that's many of you in the room. We're so grateful to get to be a part of the co-design, co-development process. That was something that you emphasized as well. I thought that was really well articulated, is that we need to start with the problem, not the solution, then co-design, co-develop that together. Because tech companies create wonderful technology. It may not at all fit in a single space in healthcare, right? It's great when the number of emails and calls I get in any given week about the solution that's going to save all the lives and prevent all the suicide and solve all the PTSD and all the things, I appreciate it, and I respect it, and I know you love it and care about it, but unless we've co-designed it together and built it from the problem to the solution, we run into a lot of barriers in that process. The other thing that's been really critical to us, you'll hear us say this if you talk to us for very long, is heads and headsets. People ask us all the time, how have you seen this kind of adoption and engagement? Singularly said, heads and headsets. Dr. Kirsch, she's in here now. Dr. Zhang is here as well. There's Dr. Kirsch, raise her hand in the back. Dr. Zhang was in here a moment ago. So my boss and my boss's boss, advocates for immersive technology, but about 2 years ago, Dr. Kirsch was at the Immersive Summit for the first time, got a little idea of what was going on, but about 3 or 4 months later was at a demo day for Mission Daybreak, which is a suicide prevention grand challenge, and a few of those solutions were VR-based. So she tried it on, and I think she would tell you, you guys could all go talk to her afterwards, so everybody just go right to her when we're done. But she can still remember how she felt in that experience. I remember the next day we were standing in her office, and she said, it's kind of like butts and seats, but it's heads and headsets. And that is absolutely correct. And so that's been true for us with our patients as well. At that same event, we had a patient that was a panelist, and she said, you know, it's great you're doing this for your executives, getting them to see and experience and hear and all the things, but are you doing that for your veterans? And at the time, we weren't, but now we are. So we created this event we call the Veteran Experience. We've hosted this at 4 of our medical centers so far. We have 4 more that we're planning. But in those events, we basically go into a common area at the medical center. We bring all the headsets that are at that medical center. We open the door for 4 or 5 hours and just allow veterans and staff just rotate through. Just try it. Just see what you think. Give us feedback. Let us know. What would you like to see? How would you like to use it? So of those veterans, 253, 60% of them had never used VR before. That number with the first few sites was higher. So we're starting to see that number go down, which is exciting. 95% said they'd like more. 91% said it was easy to use or very easy to use, which honestly debunks an assumption, right? You heard Carrie say early in her testimony that she thinks older veterans should be given more access to this. Another thing we hear all the time is, will they actually use it? It's so complicated. But they don't seem to think it is. So I think we need to continue to drive toward what they're actually saying. The other group of people we got to do demo day with, you guys said you're familiar with the VA, so do you appreciate that our board of directors is Congress? Right. It takes an act of Congress, right? So we got to go. This is an idea Dr. Kirsch and Dr. Clancy had, her boss, and said, you guys should go do a Hill demo day. And so we did. We had more than 80 people show up. And what was really fascinating, I thought, was that you've got these people in this really stoic environment, the weight of the world on their shoulders. They're trying to figure out how to have a conversation with the other person. Very, I don't want to say grim, but it's just not a happy feeling place. You know, people aren't walking around slapping each other on the shoulders and telling jokes, if you know what I mean. So they come in like that, and they leave completely different. And not only do they leave and their demeanor's different, they bring people back, which is huge, right? That kind of advocacy and evangelism is not a small thing. So average rating 9.6, but you can see some of those one-word things that they talked about as well. So we then realized that we can't do this by ourselves, as we said the whole time. You've heard the concept of collaboration being critical. So we brought together an executive roundtable. Some people knew a lot about immersive technology and were there from day one, and others had no paradigm. But they've had a deep history in scaling technology, in disrupting healthcare or other industries. And we wanted to get their ideas around how do we help make this more normal. So we actually published a white paper. It's available on our webpage. But we talked about these priority focus areas. How do we make sure we're mindful in how we're gathering this evidence? How do we then get the knowledge out there? How do we keep patient safety at top of mind? And actually, we expanded that to patient safety, staff safety, system safety. And then, as we talked about to begin with, if VA has a history of laying the groundwork for disruptive innovation that transforms healthcare more globally, how do we get this technology outside of just what we're doing in VA? So I'm going to cruise through these. I'm happy to talk about any of these if anybody would like. These are broad generalizations of some of those projects I mentioned, but some of the strengths that we've identified and also opportunities. As I mentioned, co-development really critical, collaborations, diversity, that can be across patient populations or also across clinical disciplines. This is not just about doctors and nurses. I'm a pharmacist practitioner. We have social workers. We have people from all different walks of the clinical journey participating in this process. We want to continue to lean into the human-centered design approach as we're talking about this. Data and connectivity concerns, you'll hear that from everybody, right? How do we solve some of those together? Also keep in mind the design and development of the hardware, better graphics, easier to use, some of those concepts. And then site level agreements, that's more on our side, like how do we make sure that people show up and do the thing that they told us they were gonna do? When we talk about our community living centers, so now we're expanding outside of the actual inpatient, outpatient setting into places where people are living, and we're using this technology there as well. There was a lot of support for clinical documentation and implementation, which on the business side of healthcare is really important. These particular facilities, again, if you're thinking about a residential area, they get into the rhythm of using this technology more regularly, which was really important from the data collection. There were multiple sites in this particular effort. 9 sites were participating across a geographical region, so they were able to help each other around this single particular implementation, which was helpful. We've also learned in-person trainings are good. If people have a history or any sort of experience with the technology, that's less necessary. You can do more remote virtual trainings. But if they're new to it, sometimes it's good to have somebody there in person helping them out. Connectivity, busy schedules, those kinds of things, I don't think that's unique to us, but certainly things as we all start to think about addressing barriers are some really important ones. And then as we start to send more devices home with patients, what does that look like? When we say pre-purchase licenses, that just means basically that we're buying a bulk from upfront and then helping people disseminate them more easily so that individual sites don't have to purchase one at a time. You see this again, easy to follow documentation, collaborations, continuous learning. There are themes through all of these things. So while we may be talking about different settings, there are certainly opportunities to identify things that we can all, again, do together. So content development has been one that we haven't done a ton of, but where it's been helpful is we can tailor content to VA and veteran-specific needs. Again, that human-centered design approach. Collaborating across offices, I've given you guys a taste of how complex our organization is. The more we can really lean into those subject matter experts being the voices at the table, and we just sort of manage the tech part, we found there to be a lot of value there. Standardizing design processes, I think, is going to be something you're going to hear more about from us in VA over the next year. But the ability to have a seamless and consistent user experience and building that standardized process for sure. So, lessons learned. If you're here from industry, these are some things we'd love for you to keep top of mind. Co-design, co-development. I've said it a million times today. Clear information about connectivity. What is required? Do you have to be able to stream it? Can you be in kiosk or single app mode? Those things are really important. Comfort and usability. These, we just need people to really interact with and connect with these devices in an important way. And be prepared to work with health IT and privacy requirements, which means have a lot of patience, a lot of resilience, a lot of tenacity, all the things. If you're here from a healthcare system, your champions are they are your asset. If you don't have a champion, you're going absolutely nowhere and you'll have a bunch of devices in a closet that never get used, right? Which is another story that we're trying to avoid. Collaboration, really critical. You've heard me say it a bunch. Clear examples of how to use. Don't just hand somebody a device and say, hey, or use this in healthcare. Give them some specific opportunities, examples, patient stories, Give them as many tangibles as possible, because we found that people really do want to use this technology. They just don't always know how, and they're not necessarily the early adopter that maybe you are. And then the end user processes for access and data collection. That's going to help us all. So quickly run through some of the resources if this is helpful in any healthcare systems. I mentioned we have an XR network that's on Teams for us, but just basically a common social space where people can share their challenges, share their lessons learned, come together with questions. Hey, I just published an article. Everybody, here it is. That's our internal space. We have 2,500 members there. We also have templates, standard operating procedures, so people don't have to keep reinventing the wheel. Communities of practice have been really critical to us. We have one that's broad in general, and then from that have spun these others where people have asked us to focus, and then we provide continuing education across 20 different disciplines right now. That's available on demand. These two, the playbook and the intro guide, are publicly available. If you go to our website, you can have access to those. The event guide and engagement toolkit is really specific to our facilities. How do they facilitate those veteran experience events, checklists? Certainly a model if that would be helpful to anybody to borrow and use. What's next for us? Continuing to increase access to headsets, keeping diversity and inclusion, accessibility in mind, continuing to think about how do we standardize training and education with this technology for patients and for providers and for our staff. And also the data part, right? The part we're all trying to get to is how do we begin to build formularies around this? How do we begin to understand better where it's most valuable, most critical? We did a podcast with the undersecretary, who's like our big boss or something like that. But you can hear a lot of patient stories in there, so that's why we share that. Would love for you to take a listen. We have these resources, our webpage, which is the VA Immersive innovation.va.gov. You can learn more about our entire office and the work that we do across VA, including advanced manufacturing, care and business models, simulation training and education, building the innovation muscle of our staff with the innovation ecosystem. We have the Fusion of Marketplace. It's best practices of what's happening in VA, and you're welcome to borrow and steal any of those things you find there. There is a community around immersive technology there. And then my personal favorite is our YouTube playlist, where you can hear more stories like Carrie's about some of the things that we've done. And then finally, March 20th, we had a paper come out. It took us a year to write and 7 years to create, but in the New England Journal of Medicine. Thank you. Thank you for that.
Thank you very much. There's one or two questions.
Thanks for your talk. Why, coming to this conference, is there actual women here?
Hey!
And in technology, it's still at 28% since '84. And so I'm wondering, with all the great pictures of women I've seen in your slide set, are any developers?
We don't have a ton of developers that are specifically VA staff. We mostly partner on development right now, in part because by design we're a healthcare system. And so those are some of the things we're trying to identify is, do we build that capability within our staff, the development? We're certainly partnering with companies that are led by women. I mean, Cleanbox, Trip, Helium, all of those. So we encourage and advocate for, but as a part of the rest of the work that we're doing. Is that helpful? Yeah, sure. I defer to you.
Final question? Yeah.
I myself am a veteran. How can I be connected both to the virtual reality network and the 3D printing network? That's another thing I'm interested in.
Absolutely. Reach out to us at VA Immersive at va.gov, and we'll get you connected to the right places. Yep.
Okay, thank you very much.
Thank you.